Yes, so I hope this won't be too off topic because I'm not going to really talk about genomics at all, but I am going to talk about resource allocation, in particular how cost effectiveness modelling can be used to help make decisions about resource allocation between different subgroups that might be at high risk of a disease. So in this case, type 2 diabetes. So there are over 3 million people with type 2 diabetes in the UK, and this is increasing, particularly due to the risk factors of age and obesity. But there's many other risk factors of type 2 diabetes, including smoking, lack of physical activity, family history, and previous diagnosis of gestational diabetes. And we know that certain population groups are at particularly high risk. So, for example, people of low socioeconomic status, and also certain ethnic groups. So, for example, South Asians are at particular high risk. And like all health resources, public health resources are limited, and they must be allocated in an efficacious, cost-effective and equitable manner. So there's been lots of models made of diabetes prevention interventions, but in general they haven't been able to compare different interventions, and they haven't been able to decide who these interventions should be aimed at. So we've designed a model which we call the SOFA Diabetes Prevention Model. That's School for Public Health Research, and it's been developed to forecast long-term health outcomes and healthcare costs for evaluation of diabetes prevention strategies. And it's an individual level patient simulation built in R that models the evolution of individual level trajectories of metabolic factors, so things like body mass index, blood pressure, cholesterol and glycemia. And the individuals within it are sampled from the Health Survey for England, so it should be representative of an English population. So in brief, what happens in the model is that it's updated in yearly cycles. So first of all, the age is updated. The model then estimates how many times an individual visits their GP. It estimates a change in the 4 metabolic factors that I've already mentioned. Then it estimates if an individual undergoes screening, which is a random event depending on whether or not they've gone to their GP or not, for diabetes, hypertension and dyslipidemia, and if so, whether they're diagnosed and prescribed treatments. Then it will estimate if an individual has a cardiovascular event, and this depends on whether they've had a previous event or not, including fatal events. It will then estimate the risk of microvascular disease, so this is diabetes-related complications in individuals with high blood sugar. And then it will estimate the risk of cancer, cancer mortality, osteoarthritis, depression and other cause of mortality. And those are all diseases which have a higher higher rate of getting these diseases if you have diabetes. And of course the costs and the qualities are gathered for each year within the model. So we're obviously evaluating an intervention. For this particular analysis, we've just chosen an intervention that's a sort of generic lifestyle intervention based on a meta-analysis of diabetes prevention programs. And within the model, this is programmed in. We have these trajectories which are shown by the dotted line there. That's just showing the BMI trajectory. And the intervention, which has already been shown to reduce BMI, affects the trajectory. So it has caused a reduction in BMI. And then, because there's not much data on how long interventions are actually effective for, we assume this diminishes over 5 years, and then people go back to their normal trajectory. And we run usually 5 million individuals through the model at a time and sample them, simulate them under control and intervention conditions. So for subgroup analysis, we've chosen 6 different subgroups who are at high risk of diabetes. So age is obviously a risk, so everyone between 40 and 65. A high BMI over 35, which is above the 30 is the level for obese, so it's higher than that. South Asian ethnicity, low socioeconomic status, so this is the lowest fifth of the population. HbA1c, which is a measure of blood glucose, greater than 6, so this is high risk for diabetes. and finished diabetes risk score, which is known as FIND-RISK, and it's based on a series of different diabetes risk factors greater than 0.1. And obviously all of these have different proportions in the population, so to standardise it, we've chosen just to allocate this to 2% of the total population, which will also reflect resource constraint. You can see from this quite complicated table that all of the 6 subgroups have different sets of risk factors. So the average age is different between them, BMI is different, HbA1c is different, socioeconomic status differs in what proportion of the population it's affecting. So they're all going to be getting diabetes through different reasons, effectively. So when we run this, we're not really surprised that the intervention is cost effective compared with the control in all 6 subgroups over a lifetime. It's also cost saving, and we find that the South Asian subgroup have the highest net benefit, so it's most cost effective to implement the intervention in this subgroup. But actually the most costs are saved in the people with high BMI. The most QALYs are gained in the South Asian and the low socioeconomic status groups. We can also use the model for, you can actually see how many people get diabetes, how many extra people get diabetes, or fewer people get diabetes and cardiovascular disease. And we actually see that although the South Asians are the most cost-effective group to target, we're not actually reducing the number of diabetes diagnoses in this group at all. Actually, most of the effect is through the cardiovascular diagnosis. And it's the HbA1c and the FIND-RISK groups where we're actually reducing diabetes diagnoses the most. The other thing that's quite interesting is that the point where the intervention becomes cost-saving differs between the subgroups. So although they're all cost-saving over a lifetime, none of them are cost-saving after 1 or 5 years. And when we get to 10 years, the intervention is not cost-saving in the South Asian and low socioeconomic status subgroups, but it is cost-saving now in the other subgroups. So basically the conclusions of this is that this model can enable the benefits of lots of different types of interventions to be compared within different population subgroups, and these do tend to produce substantial gains in health, and they save costs over the course of a lifetime. But population heterogeneity does impact quite a lot on the differential cost savings, QALY gains, the actual events you're avoiding, and the timings of those cost savings. So decision makers need to decide what they're actually interested in. Do they want to focus on diabetes or cardiovascular disease? Do they want the intervention that works best over a lifetime, or do they want to save costs in the short term when they're allocating public health resources? Several points to note with this model is that at the moment we're assuming equal efficacy effectively of the intervention for all the subgroups, and this may not be true. So in fact it almost certainly isn't true, because we know that people of low socioeconomic status, for example, don't tend to take up these type of interventions as much as the general population, and we don't know whether the interventions will be as efficacious, for example, in people who may have a family history. We don't know whether all the metabolic factors work in the same way. There's obviously also some equity considerations. Is it ethical to treat one high-risk group, for example the South Asians, where it's most cost-effective, and not the other high-risk groups? That's something people need to decide. And something we can do with the model, we haven't done it yet, is that there will be some people who fall into more than one subgroup. In fact, there may be people that fall into all 6. And if we target those people, we might find that the intervention is even more cost-effective than we've already found with the individual subgroups. So I just want to thank the other people who worked on this model. Penny Breeze has actually done most of the work in developing the model, and there's a whole list of other people in SHA and elsewhere who've been involved in this model. So thanks.